Are there any questions from the floor to get this discussion going? I guess, David, could I just ask, while people are thinking, you talk about live data. Can you just tell us what that really means? Because, you know, it takes a while to see where you're trending, and I mean, I like the pictures of them just dropping up and down, but in reality, you probably don't want live data, but you want pretty contemporary data.
Yeah, I guess with a run chart, you've got to start somewhere, actually, and when you've got the first one case, it means nothing. The next 5 cases, it still means nothing. Okay, you might get to 20 or 30 cases, actually, before you can say, okay, well, this is how we're performing. But actually, if you've got a rolling total from then on, actually, you're adding and subtracting cases, so adding and subtracting performance as you're going along, actually, and then the trend line becomes statistically significant rather than just a comparison between two numbers over a period of time. So how frequently we should be actually getting the downloaded data, I think actually it depends on the size of the organisation. You've got a small hospital, it probably isn't quite so important to have it sort of so regularly, but in a big organisation I think it probably does actually matter. The advantage actually of having automatic download of the data actually is it means that someone doesn't have to actually sit down and actually send it to the hospital that's concerned. If we have a program set up so that it goes, the data is downloaded and goes to a central resource who then put it together and analyse it and send it immediately back. That's probably the way we need to go.
Yep, there's a microphone about to appear, otherwise you'll become hoarse.
Thank you. Question for Audrey. I'm a poor, humble anaesthetist at my not so small hospital, and I'd like to get involved in this and like to see, see us contributing data to something like this. Everyone's busy. There's, only so many hours a day, and hopefully the consultant anaesthetist and surgeon are in theatre and saving lives. And so, how does the health department, in a practical sense, help with this? Because I go to the boss of the hospital and say, "Can we have some help to do this?" And he says, "I'd love to, but we've got no money."
If I can be perfectly honest, that's part of the reason why I added the slides about the new legislation. So I think in the first case, that conversation needs to be had with the hospitals in terms of freeing up the resources. And some of the work that has come out from the review that was undertaken, in particular, given that there is a reference specifically around resourcing people, having that as part of the job plan to do clinical audit, that would be some of the work that we, along with the hospital board chairs and CEs, will have to work through as to how we actually do that. So
Peter, can I ask, how expensive is it to do this? To do this process. I mean, you've been doing it. Is it costing you an arm and a leg?
The database is free because we used RedCap. Those of you who may not be terribly familiar with the research world, is pretty well the industry standard for collecting data of this sort nowadays. So that's free. Our major cost, I suppose, Maddern Holmes, who was the research fellow who did this, we created some research fellow jobs using health service money and manipulating the rosters last year. So her research time was free.
So this is slave labour you're talking about?
Let's just call it incentive. All right, she was on an incentive to work hard, produce results, and then we'd get her a job as a surgical registrar. And I'm pleased to say that both sides met the bargain. So, look, there's time and effort, and you have to put in the hard yards. I would like to believe that once the system and process has been worked out by the clinicians who have to take ownership and leadership and drive this process, that once it's been driven through and established as a process and the quirks are worked out, actually this is high level but administrative task in completing these sorts of data fields and data sets, an area which is chronically under-resourced in the public sector here, as it is and was in the NHS in days of old.
Sorry, there's a question that's coming. There you go.
In follow-up on that, who would we be anticipating is going to enter this data? Because the experience and expertise of the data entry personnel would really influence that output of the data?
That's what I mean. You've got to get it established. You've got to teach the people what to do. But if you construct, we spent quite a bit of time this afternoon talking about the nitty-gritty of the database. But if you construct it with rigid drop-down lists that are understandable by what you'd call skilled people who've had what this means and doesn't mean explained, the sorts of people who do coding in cost recovery in hospitals, they generally speaking do that work to a very high standard. Once they've been trained up to that standard, where it falls down is either if there's not enough money to train them, or there's not enough money for them to keep up with the work. Now, that's a resource issue that goes back to your funders, whether that's Western Australia Health or New South Wales Health or whoever Health. They've got to pay for that, otherwise they get crap out of it at the end, because we can't work without information.
So this would be non-clinicians doing the data
I think
entry?
eventually that's where it should end up. But the clinicians have to take ownership and leadership and say that this is something that matters because it will produce results.
Yeah, I think I actually retorted in my comment actually about quality assurance versus quality improvement. What bothers me actually is the amount of money which is actually spent on quality assurance. Okay, and it's huge just to make actually governments feel comfortable and happy. It means bugger all, to be honest. Okay, it's really quality improvement programs actually, and the number of them that will actually improve the quality of your service. Look what WAASM has actually done, that reduction in mortality. Okay, as James will tell you, actually, it's dropped 35% mortality per 100,000 in this state, year after year after year, since actually we started WAASM. Look at a place like Flinders, which actually has reduction in variance simply by having protocols of care, okay, in every single department in that hospital. Okay, over the last couple of years, their mortality has actually gone down, and they've reduced the variation in their care, and they've therefore reduced the cost. Okay, this is where the money should go. Okay, I think a bugger actually if the minister feels happy, it's irrelevant to me. What matters actually is the public and how they get looked after.
David, before you put the microphone back, you did show data, though, that reflected shorter length of stay, saving money, all of which is true. The only trouble is it'll just get immediately filled with other patients that need care and they get managed more quickly. So there's never actually dollars in the hand to spend. You've done a great thing for your community, but you haven't saved a cent.
Well, the costs continue to go up, actually, and the reality is that we can't afford to continue funding health at the way we actually are. We're now actually 10% of GNP in this country, actually. We've hit the 10% mark finally. It just can't go on. So we have to improve our efficiency. And if you look at how much money do we spend actually on reprocessing, because if we cocked it up the first time, we have to do it again. Okay, by reducing those errors, we actually save an enormous amount of money. Okay, just setting up the acute surgical unit, for example, and the Conradi data Marina showed, that was a significant reduction in the length of stay, simply by actually providing an anaesthetist and a surgeon and a theatre and a patient at the same time. So we can improve our efficiency, and this is one way of actually doing that.
Some of the data that we want is routinely captured, and we don't need to re-enter it. So data about when patients turn up to the hospital is routinely captured. We shouldn't be re-entering that. Theatre management system should be electronic, recording when the patient is booked, when the patient goes to theatre. We don't need to enter that. If the denominator data on the database was the theatre management system, then consultants would have an incentive to make sure that the right operation is recorded, that it is actually the right surgeon doing the operation. And I don't think we should be going out looking to re-enter data. We should be giving consultants their data, and if they don't like the fact that they did the operation and it wasn't recorded, then they need to make sure that it's recorded correctly on the TMS. Some of it we can actually force change. I mean, I think the biggest single important finding out of our data, reflected in the UK, is that patients should have a risk assessment before they go to theatre. I think you can argue about which risk assessment, but the fact is by doing it, it makes people think. If that had become part of the booking system, which it could be electronically, so you couldn't actually book the patient without completing the risk assessment, it would A, force it to be done, something which we've shown will halve the mortality, and it's only done once. And so there's a lot we can do with quite simple data. I think in WA, looking at the data that Audrey presented about run charts, and I'm open to be corrected by others on the floor, we will be able to produce run charts exactly like that. After all, the 4-hour rule, I see data literally every week about the times of people coming into ED, how long it takes, and they're producing the run charts for the 4-hour rule already. To do it for emergency laparotomy just requires a couple of data fields to be changed, and the data is right there for us. So I think a lot of this will actually be generated very easily, very quickly, and at very little cost.
But James, how much time am I going to have to spend doing this risk assessment?
Well, to do a risk assessment on a patient using PPOSM or NILA takes probably less than a minute, and as I've shown you, halves the mortality. I would think doing an assessment that takes less than a minute and halves the mortality is time well spent.
There's a question.
Yeah, thank you very much. Excellent symposium, and thank you for your presentations and interest. I'm particularly interested in how you apply this in networked services. I mean, it's a long-standing discussion in Western Australia about the standard we're trying to provide is a standard that reaches all patients. That includes people in network secondary hospitals, people who live in the country. How do you extend the quality framework across a network of service providers? And how do we measure that in this system? One of the challenges for the intensive care data set has always been the issue of patient transfers, which ends up corrupting some of the data.
We discussed the issue about transfers today, and I think in the UK and NILA, 4% of patients were transferred. In our data in WA, it was 25%. I think there's a fundamental difference. Personally, I would like to see a risk assessment done on any patient before they're transferred, because some of those patients, you'll say, this patient's got a 50% chance of dying, they're 80. Do they really need to be transferred to die en route, where they could actually be managed at home? Even if they were transferred, the fact they've got a high risk would actually make everyone more acutely aware of what's going on, and they wouldn't arrive in the tertiary hospital ED and lie there for a number of hours. They'd keep processed. So I think there's a lot to be said for doing a risk assessment prior to transfer. It would take very, very little effort to do that. But by and large, the standards need to be pretty well the same.
My perspective of this is that we're a bit bipolar in Australia when it comes to transfers and distance and such like. We have vast distances on a scale way beyond anything in Europe and substantially most of the rest of the developed world between a very few of our people and most of our people. Australia is amongst the most urbanised of all developed countries. So the enormous majority of our population live in our major towns and cities. But we still transfer an awful lot of patients within those. Numerically, the bulk of our transfers come from within the hospitals which are within sight of ours. Now, you could question whether they should be admitting patients of this sort at all when they do very low volumes and they're very close to the significant hospital. But if you are going to admit them there, risk assess them when they get there and decide, can they be dealt with here? And if so, that's fine, and if they can't, get them to a place where they can be dealt with if they need to be dealt with. Because not every emergency laparotomy needs an operation within 6 hours. It's the small bowel obstruction that may or may not settle. But if they can't be dealt with in that hospital, don't wait till they've gone off and now need an operation and now you need to start buggering about trying to transfer them.
There's some data out of Mount Gambier over a 5 or 6 year period that showed its emergency laparotomy rate by the same sort of criteria as we've heard today was about 8%, and those that are transferred out was also 8%. So that it is about timely management and appropriate consultant input. So, I mean, I think we can achieve that. And Mount Gambier, for those of you who don't know, is 500 kilometres from either Melbourne or Adelaide, so it's remote by normal standards, perhaps not as certainly remote by most Australian standards. Sorry, James, you were going to say something? No. Yes, there's a question. Yep, thanks. No, hang on, wait, no one hears you. Right.
Sorry, I can hear that all the people presenting this talk were from privileged hospitals in the good hospitals, central hospital. What about people from the rural area? Many things say that can be applied very simply. For example, just as a few examples I am saying, CT report, you want to be as quickly as possible. Sometimes in Albany, we used to have wait 4 hours for the report to come from London. Come from London because we have a connection with some people to bring it from London. And transfer to Perth. Sometimes you call the RFDS, tell you they are coming in half an hour. Halfway, everything prepared to patient was very risky to take him to Perth, and then halfway, sorry, the weather has changed and they can't refer him, they can't take him. And patient delayed, and you have to call back the theater staff, and theater staff, they don't want to come, and the only one who will get in trouble is the surgeon.
It depends on how small the hospital is, what the facilities are. But in fact, when I worked in Kalgoorlie, I got a much better radiology service there than I do in my, I get a consultant read scan. Now, I don't know the consultants, so it might be that they're not a very good consultant, but they may be the world's best consultant who's just doing a bit of, but the fact is I actually got the result within an hour. And I could talk to the person if I, wanted to confirm something. So, the tyranny of distance is actually being, certainly for those sort of things, I think reduced by the fact that we have telehealth and people can send images over long distances. You can't get rid of the fact that we have a state that, you could travel 4,000 kilometres from one side to the other, and sometimes that's going to induce delays. Nobody can have complete perfection in that sort of environment. I think you just have to, sometimes that's going to cause problems. I can promise you there's just as many problems sometimes just transferring people 400 metres in a major hospital.
There's another question.
I was going to say there's an elephant in the room, but it's more like a little possum in the room. In all of these, you haven't mentioned children at all. Are they to be included?
Well, look, we set out to emulate NELA, and NELA was adults over the age of 18. There has actually been some discussion about whether we should include children here, but in fact the number of laparotomies is very, very small. In principle, I'm not against it, but it's not where the major problem is going to be.
You obviously don't feel that that's... I'd be interested in your response to that.
Well, I'm not sure that there isn't a problem. We won't know until we've looked at it.
No, until you... That's of course very true. We have another question over here.
I think the concept's fantastic. The query, in terms of enforcement or incentivisation, or I'm sure you've had discussions on how you persuade all the units to do this. What discussion have you had? Are you going to enforce it, link it with CME? Are you going to have it the same as the audit of surgical mortality? Or are you going to look for voluntary contributions where obviously you will miss a large number of centres because they will not submit data? This is obviously looking at a national perspective rather than with the WA alone.
When we set up the mortality audit in 2002, there was sort of indifference, really. No one's going to stand in our way, but no one's enthusiastic. It's quite different, this. I mean, there's enormous enthusiasm from the colleges and people, so I think it will be very different. The world is also very different. The health department have been very supportive of us over the years, but they now have got an enforcement, as Audrey has said, and they're going to say, as the system manager to the hospitals, we expect you to collect this data, and the hospitals will have to do it. I also think as hospitals put the data out into the open, bearing in mind that this will not be protected by QP, and you will be able to see the data, that those who don't take part will be, for want of a better word, humiliated, and will want to take part. And it's interesting, I was part of the talk I'm giving tomorrow, I was looking at data about thrombectomy for stroke in the UK, and they've just published their latest data for the whole of the UK, named hospitals up to including April of this year, for the previous year. I mean, they're providing, named data, real time. You can see how your hospital's performing or not performing, and we just have to get the data out there, put it in front of people, and all the evidence around the world is that you put data in the public domain, people change their practice. That's what we've got to do. And I think we have to accept Australia is a long way behind. I mean, your national audit on cancer, why aren't you putting it out there with named hospitals, named surgeons like in the UK?
So we're going to name the surgeon who doesn't do a very good emergency laparotomy? James?
No, I think the situation...
No, microphone, that's why we give you one.
Situation for the emergency laparotomy, it's actually a whole hospital process. I mean, you can be the best surgeon in the world, but if the patient's been lying in a medical ward for 2 days with peritonitis, you're no good. So as far as the emergency laparotomy is concerned, it'll be done down to hospital level, because what we're looking at is hospital process. Do they get processed well in ED? Do they get to theatre in time? Do they go to ICU? And none of that's outside the remit of the surgeon. And as you showed the data, and exactly what they showed in the UK, by and large, the medical people do quite well. Our figures would have been better if we included fellows. We deliberately decided that the standard was a consultant, not a consultant fellow. But the fact is, most of the non-green squares related to the hospital and not to the clinicians.
I was just going to change tack slightly, actually. I'm just wondering what people thought of Marina's comment, actually, about who should run this actual service. We're at a point now, actually, we're actually developing acute surgeons. Do people think that's a good idea?
Sorry. Is there any... I mean, in fact, I was going to ask Marina whether she thought we could actually afford this system. I mean, already now we've got a health system that's buckling, and now you want to have an upper GI, a colorectal, a breast endocrine, and an emergency breast surgeon, a concept I haven't fully grasped. And also, but perhaps on that, just to respond, how much work really occurs between, say, 10 at night and 8 in the morning that couldn't be held over? I mean, obviously there are cases, we all know those, but in fact, if we have daylight surgeons available, you don't actually have to change too much then, because they're actually in their working hours.
Sorry if I didn't clarify that. I think that's what I meant. I think in our audits every week, we find out that well over half our operative work is actually emergency work. So we're paying, 3 or 4, in a big tertiary hospital, we have 3 or 4 surgeons doing colorectal work, we have 3 or 4 surgeons doing upper GI work, and yet more than half of the work that's going on is emergency surgery. So why not have 3 or 4 surgeons providing that emergency surgery? And you're absolutely right. When the experience improves in the emergency surgeons, the amount of operating done at night reduces. And with availability of daytime theatres, our nighttime operating rate dropped dramatically. And interestingly, when we moved hospitals and, with the normal learning curve of any new hospital, we didn't have the same sort of daytime access that we used to, or as much access. Our nighttime operating rate went up again, and as we've improved our daytime surgery, our nighttime rates have dropped. But it's not only the theatre, it's the whole package, it's the whole team. And having someone available and exclusively available to do that emergency surgery, I think is just as important as having the theatre. So it's the whole package, not just either the surgeon or the theatre.
My personal view is that certainly in Perth, within a few years, all the surgery, emergency surgery will be done by a GI surgeon. In the UK, they're already having discussions about whether the patient should bypass the first hospital in exactly the same way as they would do for trauma. And I would agree with Peter that we should be making decisions as to which hospitals are going to do this surgery. And for some hospitals, that will mean they don't do this surgery. Now, I appreciate that might be controversial, but it's I think that's happening. If you say, where are we going to be 5 years from now? All the emergency laparotomies will be done by a GI surgeon. Whether we get there by disaster or by design will come back to us.
There's a question.
My question relates to the NELA data. My understanding of their initial process was that they assessed all the hospitals and the structure of the hospitals to determine how they provided their emergency service vis-a-vis, like we've been discussing, were consultant surgeons available, was there theatre available, etc. Is that proposed in this ANZILA?
Yeah, we need to do that. Hospitals in Australia are peer classified. by the government through the Independent Pricing Hospital and also by AIHW. They actually classify some hospitals in different groups, so 2 government organisations, different peer groups, not very good. But it also looks at the whole hospital system. So just to use an example, in this town, we have a hospital with a very busy ED, with an ICU which can cope with any general surgical emergency, but it's not a peer review hospital because it has no out-of-hours interventional radiology or gastroenterology, so it can't be if you like, a principal referral hospital. So we need to actually do an organisation to find out what the hospitals do, because the current classification is for the whole system, not for emergency laparotomy.
Mary, are you going to transfer your emergency laparotomies down to the big hospital down the road?
We already do. So if they've had a risk assessment and they have a high risk of mortality, they need major organ support. So we do have an ICU at Midland. It's small and it's a level 1, which means we can only ventilate for 24 hours. We cannot provide any other organ support in terms of dialysis. So they're very clear-cut cases. If they need interventional radiology or interventional GI, then they're also very clear-cut cases, and clearly if their mortality is high. So we already do, and that may be reflected in the fact that our mortality is 0.
David.
There is a workforce issue, and yes, I think it's ideal, and their data is there to show that specialists doing specialist jobs, whether it's acute or not, to actually get better outcomes. But the reality is, even in our tertiary institution, if you understand me, a lot of the work we do actually is perinatal abscesses and appendicectomies. I just cannot imagine actually a specialist colorectal surgeon or an upper GI surgeon spending their time actually doing that. So we proposed a model a number of years ago, but during a group of general surgeons saying, what about the idea of actually having a second on call so that you had someone to call upon if you needed it out of hours. And the reality is much of this stuff can be delayed till the next day. There's no question about that. And it'd be far simpler to set up your elective versus emergency mix for your specialties so that you've got someone available to deal with it. That would therefore require actually an institution of a particular size. And you're probably looking at 600 beds plus to be able to do that, to have the staff around to actually do it. The real issue really is in the smaller institutions, and particularly the country. And it's how you maintain the skills of people who work in remote centres. The model we have here in WA actually is that we have surgeons coming from the country doing a rotation in our acute surgical unit to maintain their skills. The model we proposed to Country Health actually was that we employed people in Perth so that we can actually do this as a formal rotation. The problem with that actually was no traction from government, sadly. But this plan's been on the table for 5 years. We're still trying to actually make it work. Because if you ask the provincial surgeons, they cannot not find enough staff to actually staff their hospitals. You've got people walking around in the metropolitan areas underemployed. It's really about getting the balance right, actually, because I know many junior colleagues are unhappy about going to the bush. I do it occasionally, and I do tendon repairs and look after burns and all sorts of things. Actually, I must say I quite enjoy it, because it's dredging up probably 35 years ago from where I used to do it. Do I do it well? That's the next question. But really, I think we really need to put together. Simon asked a question about networks. The networks have to go beyond just your own region. They've got to be countrywide, because the people working in the bush do it tough.
Well, as you know, we in South Australia have rotating 365-day-a-year service in Port Augusta, provided by a dozen surgeons from Adelaide who go out there, and we concentrate the specialties when they're there, and they can, admittedly not as well as a colorectal surgeon, but they can deal with emergency laparotomies in the middle of the night. And I think it's a model that's absolutely analogous to the West, and I'm surprised it hasn't been picked up by your department. But I'm sure Audrey will be doing that. Yeah,
I think
good.
I think one of the reasons, I think there are 2 reasons why the mortality is low in WA. The first is that 75% of the emergency laparotomies were done in a hospital with an ICU. And all the evidence is that ICU is an important marker for failure to rescue. And we're, if you like, failing to rescue these patients before they rescue. So I think that's important. Only 2 of the deaths occurred in hospitals that didn't have a level 1 ICU. The other thing, to go back to the goals of care, is that we've looked through the mortality audit, at futile surgery, and we've actually now looked at 3 years of data, 2010, 2015 and 16. In 2010, we had patients dying in the anaesthetic room. We had a number of patients who had open and closed laparotomies. We had none of those patients in 2016. And I think part of it is that the focus that we've had on avoiding futile care has stopped some of these patients coming to theatre. And that's why I think the goals of care, as Audrey put up, I think is a really important part of the data collection process.
Well, on that note, it might be, I think there's alcohol waiting, so on that note we might bring this to a close, but could I ask the audience to thank our panel for what's been a great session. Good.